all I need to say, the first speaker is Zoe Adey-Wakeling, and I haven't got the name listed. Deb Bourchier, yep, who are presenting a paper titled Telerehabilitation Outpatient Clinics for Rural Stroke Review and Driving Assessment. Zoe Adey-Wakeling is a rehab physician working for the Repat General Hospital and Country Health SA. She has a particular interest in neurological rehabilitation, telerehabilitation and driving. She's a PhD candidate with research exploring the identification and management of hemiplegic shoulder pain. Zoe.
Just work this out. So good afternoon, everybody. Deb and I would like to thank you for the opportunity of speaking today, and I think following on from the first plenary session, we've been given a really good background of the context of the need to evolve telehealth services and some of the evidence to support it as an efficient way and of delivering services, and something that's certainly acceptable to the client population. By way of introduction, I'm one of the rehab physicians that visits Mount Gambier and services some of the client groups via telehealth, and Deb is our CPC at the Mount Gambier site. We want to talk about mainly the establishment of our outpatient clinic service there via telehealth, but we'll touch on some of the other telehealth services to the region as well. We've got a beautiful picture of the Blue Lake, Mount Gambier is famous for. Can't say I ever see it, but it's worth seeing if you're ever down there. I'm going to speak a little bit about the evolution of services, rehab services to the region, as well as the implementation of the telehealth, and Deb's going to go on to outline some of our preliminary outcome data and some of the trials and tribulations in achieving that. For those who don't know, Mount Gambier is a township located between Adelide and Melbourne, about 450 kilometres southeast of Adelide. The region services much of the southeast of South Australia as well as western districts of Victoria, with a catchment area of approximately 17,000 kilometres and a population of roughly 64,000. So it services a great region, but Mount Gambier is the central health service for that area. Regarding rehab services to Mount Gambier, historically from about 2010 we started having rehab specialist visits to the site. They were predominantly focused on inpatients with a very small allocated time for outpatient services. So naturally, prioritisation to those outpatient referrals meant that only small numbers were able to be seen. The frequency of those specialist visits has been highly variable over the time for countless reasons, including some funding issues. But over that time we've also been lucky enough to establish regular, now fortnightly registrar visits, which has helped the inpatient service be more consistent. The drivers towards trying to implement a more regular telehealth service, though, have mainly come from the rehab statewide service plan, which really put a focus on trying to improve services, rehab services to country, and Mount Gambier is identified as one of 4 major sites, the others being Whyalla and Berry and Port Lincoln, and telehealth was part of the way that might be able to be improved. In addition to that, we had sort of community and clinical feedback which was driving that change, and a team that was really keen to engage. The reason that telehealth was deemed an appropriate strategy was that it was a way that we could improve the access of the rural clients to that service, as well as some support between metro and country sites. The aim was to establish an outpatient service that was in line with best clinical practice, so that we were looking at things like stroke reviews within that 3-month post-discharge period and specialist reviews for driving. The components that I said I'd touch on, the inpatient services were really how it all began. We started with sort of regular telehealth case conferences, which developed then to family meetings, and then often what I sort of refer to as some of the bridging type services, where we can have really in-depth handovers between metro and country rehab transfers, as well as things like the ad hoc specialty advice for complex clients. In addition to that, and I put a little asterisk by it, the code stroke pathway, it's not a rehab run service, but obviously integral in part of the stroke journey. Focusing today on the outpatient services, we've been successful in starting a regular outpatient clinic, and it's just important to note that obviously that's in addition to some of the other statewide services which offer both on-site and telehealth clinics as well. Now, from the speakers this morning, you realise that there's a very complex cycle of things that need to be addressed to implement and embed a successful service. And the components regarding successful planning and structuring of that we really want to focus on today was the role of the CPC at the country site, as well as the development of protocols for developing those clinics. The role of the CPC, Deb, as the CPC, we'll speak to in more detail. But the role of the protocol was a way that we thought we could successfully start to address a dedicated client group to improve confidence and then educate staff at both ends about the aspects of that protocol to use. We started with a sort of an introductory planning day with a breakfast held down in Adelide at the Grand Hotel in 2012, where allied health and nursing staff from each of those key sites came down. We realised we had a really enthusiastic group of people that we could develop, and it was rapport building and idea generating, and that was a real starting point. From there, the following year, we had another training session where staff again came down to Adelaide, and we went through some of the preliminary protocols we'd come up with and really valued the feedback from all of those staff to develop protocols that were going to be, important and effective with the client groups they were working with. Deb's going to speak again a little bit more about the specific training that we had for the telehealth proctors, which is a terrible name, so we'll call them the CPCs. But if I use that term, that's what I'm referring to. When we looked at the protocols, we sort of identified 4 main client groups that we thought would be the usual focus of an outpatient general clinic, which was stroke and TI assessment, driving fitness assessment, falls and fracture and amputee. In practice, it's the first 2 that have been the majority of the client group that we've seen. And like I mentioned, trying to fit into those national guidelines. The reason that protocols were deemed a good way to start was, like I said, to build confidence in the use of the telehealth and allow clinicians at each end to have a standardised approach that meant that they could give the required amount of attention to using the new technology and have a sort of a prompt for everything else that they wanted to go through. In addition to that, meant that we were consistently meeting telehealth documentation standards, because things like consent were embedded into that document already and sort of prompted you to make sure they were addressed. It was a way of easily documenting things in a very timely fashion, electronic document that could be easily shared between sites. And in addition to that, it was a document that could be used as a case note record, as well as any communication to GPs or other referrers as appropriate. So really trying to reduce the burden on admin and support, because the roles they were having to take on were very new and challenging as well. Now, this is just an outline. It's probably a little bit small to read, but National Stroke Foundation certainly supports stroke groups stroke clients been seen at least 3 months and potentially 6 and 12 months as well post-discharge, and that's something that we're really aiming to meet with this clinic, as well as the renewed Austroad guidelines that require return to driving clients post-stroke to be seen by a specialist. Obviously in a regional community that can be really difficult to access that, and we've been quite successful in allowing these clients to have timely reviews over telehealth. Now, if I could ask tech support just to open that first document embedded in there, because otherwise I don't have a way to do that. Excellent. So that's our example of the protocol. But what we really wanted to point out with that, with the starting page of that, you have a checklist for the CPC at the regional site, and it looks at the investigations that we want to have collected prior to the consult, as well as the assessments that are to be completed prior to the beginning of the session with the specialist. So for stroke, that's things like their echocardiogram, Holter reports, any imaging or blood results, and then the assessments like the National Institute of Health Stroke Scale, which they were all trained in, and things like visual field, visual acuity, which were more difficult to do over telehealth. And as our speakers this morning pointed out, musculoskeletal things are a little bit easier than neurological, so we were using those hands at the other end to do it that way. So moving along, Deb's now going to, now the thing won't work. Deb's now going to introduce herself as the proctor, but this won't forward, if you could help her with that. Thank you.
Thank you. Well, good afternoon, everyone, and thank you, Zoe, for the invitation to share today Mount Gambier's telerehab journey so far. The need for the telehealth coordinator role came about over time at Mount Gambier as our rehab service developed and matured. The demands were increasing for the utilisation of telehealth, and it was recognised that it was evident a dedicated position was needed to progress that and propel the telehealth service forward. There was a push for funding, and that was successful in January 2014 when I commenced in the role at that time. I attended the training days that Zoe has mentioned at Repat General Hospital, and that was organised with a focus on clinical skill sets and developing clinical skill sets that were required for conducting pre-assessments and clinical screenings for telehealth designated client groups. It was an invaluable introduction at that time to the requirements of the telehealth coordinator role, but the role has evolved to be much more than that. It's actually one of planning and preparation in readiness for the consults and the clinics. It's about attending pre-assessments and screenings and on the clients that are attending the telehealth sessions. It's also about coordinating services and clients and resources that are available to us. And it's also about examining the data collections and also about evaluating our services. The next 3 slides I'm going to share with you are actually a collection of data from our telehealth collection at Mount Gambier, and it's from the period June 2013 to June 2014, and it's intended as a graphic representation of the growth and value of telehealth services at our site. I'd like at this point to acknowledge the support of our admin officer Angela at Mount Gambier, who's maintained our data collections over the years and has assisted with the provision of the data here today. This slide is really an overall picture of all of the telehealth sessions that have been conducted in Mount Gambier over that 12-month time frame. The red line on the left is the left axis, is actually the telehealth sessions conducted during that time, and the yellow line is the indication of the presence of the CPC or the telehealth coordinator role. The growth that has eventuated over that time frame has got to be attributed in part to the things that were happening over that time frame. We were successful, and Zoe's already highlighted that, in implementing our driving and stroke protocols for our outpatient clinics in that time. We've also embedded in practice our ward inpatient rounds via telehealth, and we've also established the role of the CPC in that time frame. And as you can see, in the last 6 months, there's been a significant increase in the usage of telehealth, and we hope to continue to support that and sustain that service. This next slide examines only our outpatient data, and it's our telehealth outpatient data, and it's really a representation of the commitment to cost and the commitment to on-site presence of our specialist rehab physicians. And it's about, this slide is particularly about only focusing on the outpatient clinics. So it's about the focus that was put towards developing those clinics. As you can see, the red line indicates the growth in telehealth outpatient clinics over that 12-month time, and the yellow line is the costs associated with those. It's really not a sophisticated slide. It's not meant to be, but it really is an indication, and it gives us a crude indication of what potentially can occur when a service is established appropriately in the beginning. The growth arrow, the red arrow, you can see outpatient clinics in the first 6 months of that time frame were 14, and they trebled in that 12-month period to a total of 39 in the last 6 months. That's 3 times as many people accessing specialist rehab services in country that have never had access to those services before. This last graph is about our client evaluations, and these are all of the evaluations that have been collected for telehealth in that 12-month period. And again, probably not the most reliable means of evaluating a service, because there are many variables to consider when you are dealing with client feedback and client responses. It's about what sort of a day they've had, whether it was a good day or a bad day, what reason they're presenting for a clinic, and indeed, quite often they can skew towards the positive if people are involved with them on the ground. All of that considered, we were still really, really pleased with the outcomes of the evaluations, and nothing was negative. So it really gave us, reconfirmed with us that telehealth is definitely a positive experience for all of our clients that have attended. It's also given us additional comments that have swayed towards the positive and means that it is an effective means for country clients to access specialist services. On to our case study, Mrs M. Mrs M has provided me with her photo and her permission to share her story here today with you. She's a 46-year-old female who lives in a small rural community north of Mount Gambier, and she's very active within that community. She's umpiring and coaching netball teams, and she was driving the local school bus. On the 12th of January, she presented to Mount Gambier with a left facial droop, left upper limb weakness, and dysarthria. She was diagnosed as a right subcortical infarct and commenced her inpatient rehab program. She was seen 3 days later by our visiting on-site rehab specialist and then transferred subsequently up to a metro site for a right endarterectomy. Her surgery went well, and she was transferred back to us in Mount Gambier to complete her inpatient rehab program. During her inpatient stay, she was again reviewed by a rehab consultant via telehealth and was then progressed to discharge on the 31st of January. She had a goal when she went home that she wanted to actually continue to drive the local school bus, and she was pursuing that goal diligently. She went home with a home-based ambulatory program and was keen to attend a rehab therapy program at Mount Gambier regularly. She came back to us a month post-discharge and was cleared at a driving fitness assessment and stroke review clinic to drive a car. The telehealth outpatient review further conducted 3 months later cleared her to return to driving the local school bus. It's just one story, but it does indicate that this lady was able to achieve her goals with minimum disruption to her lifestyle, and it was all through the utilisation and timeliness of telehealth and accessing specialist services through telehealth. There's been lots of trials and tribulations, as you can imagine, and we've certainly had our successes and our challenges. The team dedication is the first and foremost thing. We've got a really committed team who want to make this process work. We've progressed from ad hoc to regular clinics. We've got a best practice approach for our stroke reviews and our outpatient clinics. We've had regular ward rounds established via telehealth. We've got increasing community awareness growing of the availability of specialist services via telehealth. The challenges, and they're still ongoing challenges, are still the steep learning curve that we are all facing with the introduction of new services. Our fixed mobile unit is probably underutilised. It's still a work in progress. We still need cohorted rehab beds at our site, and that's also, watch this space, there is a pending redevelopment at Mount Gambier at the moment for a dedicated rehab area, something we're really looking forward to being able to get into. There's also been reduction across country sites with FTE positions for rehab teams, and that has poses a challenge for all of us. In conclusion, we've successfully had a staged implementation process for our outpatient telehealth clinics, and they're now embedded as a regular service and access for all country clients now established on a fortnightly basis via telehealth. There's been improved provider skills, and we've certainly developed the skills within all of the team at Mount Gambier, and the confidence is growing in the usage of telemedicine, and we've now got established routines for our ward inpatients, telehealth assessments and reviews. We're still looking forward, and we're still seeing the light and trying to make greater use of this great technology, and it really is a great technology. So we've just got to try and expand across smaller sites and look towards educating and providing support for smaller Country Health SA sites to expand those telehealth services and the rehab specialist services across country. We do need to engage our GPs, and we do need to acknowledge that there is still more work to do. I'd just like to thank you and acknowledge everybody that's mentioned on the slide, and thanks, Zoe.